All right, we are officially recording.
All right. So, LaQuentin, as somebody who's on Medicare, I'm worried about the changes and the cuts, how they may affect me with this bill, especially for those who are on disability and really rely on Medicare treatment. What are your thoughts?
Actually, I'm very nervous because as I've gone to several conferences across the country, one of my greatest concerns are number one, they're cutting out it's causing most of the plans to have to cut back on how they're spending their resources. And one of the big areas, for example, is transportation. They're taking out a lot of a lot of the ancillary benefits that many minorities, as a whole, low income people, are really depending on as far as transportation is concerned. They don't have access and way to get to the doctor. So, for example, someone like yourself, with the way they're reducing the transportation components, if you didn't have family support and you're on dialysis and you have that added experience, well, many of the plans don't include transportation anymore, or they reduce it down to 20 trips. Imagine that you don't have transportation, you have to go to dialysis 3 to 4 times a week. How are you going to make that happen?
And you say some plans. So is it that some plans included and some plans don't?
Exactly. Some plans include and some plans don't. You're starting to see some of the top tier companies. It's not blanket. They don't offer it in all locations, but some of the bigger companies have cut it out completely. Transportation, because it's costly. You think about it, they're using Uber and Lyft to get them to their place. They used to try to own their own vehicles. That didn't work, but they're using Uber Lyft. So they're paying $30 to $40, $50, $60 each way for individuals to use Lyft, and they're doing it 3 to 4 times a week.
So just jumping in here, coming from state by state, it was all different, especially with the ACA involved in Medicaid. Are there going to be differences state to state as far as states that did go through the expansion versus ones that didn't?
Not state by state, but county by county, zip code by zip code. You literally can have, you can literally be on this side of the freeway and be in one county, on the other side of the freeway in a different county, and that one side have benefits that you don't have in that other county, even down to the zip code. It is the benefits vary by zip code, by county. And some of them, they take this, like, for example, when it comes to voting, they redraw those lines in terms of who's where. Well, it's the same thing with healthcare.
So is this county by county or maybe congressional district or?
No. County by county.
Okay.
County by county. And a county can be split based upon the zip code that it's in. It is county by county. And when it comes down to the Medicaid components, what they're doing is they're making it much more difficult. For example, when I flew in last night to Vegas, my Lyft driver actually works for the state. And she says every single day they're getting phone calls, even now, of people saying, I've lost my Medicaid. And they're also implementing mandates for certain age groups to have work requirements. They have to work a minimum of 80 hours a month. Now that's 20 hours a week, but they're imposing some form of work associated with that. What I would like to see is, like, if they came up, since those individuals have to work, if they came up with some type of way they could provide and support others versus just getting a job doing anything, that it would be more strategic. For example, one of the things that get cut in a lot of areas is going to be daycare for single moms, right? So why not, if these people have to work, right? If you're going to say they have this requirement, why not create a facility or a space for those with those daycare centers, right? To use people that fall in that category that have to work to serve as caregivers or look after the kids from that perspective. I don't understand why they don't do that.
Access too smart.
That brings me to another question. A lot of people in the community, especially the Black community, don't even know that they qualify for low cost or no cost at all for healthcare. How is this bill going to make that worse for them? And what's the silver lining under that?
There isn't a silver lining. It's going to work it worse for them for the fact because they're going to eliminate those those provisions in there to reduce the healthcare costs. So those subsidies are going to get lowered. So say for now you had a $0 plan, a $10 plan, a $50 plan. Now that plan may be $100, it may be $150. So the cost of that care is going to go up. So the cost of the care is going to go up. The utilization is going to go down because people don't have that extra resource to be able to pay for those, which means the deductible in the plan is going to go up. The cost of medication in the plan is going to go up. All those benefits within the plan are going to cost you more, and it's going to cost more to actually pay for the premiums themselves.
You know, we call you the insurance man. With all these different things going on and you being involved in them, I'm really going to want to get with you and go over my plan and see how this is going to affect me, because I have Medicaid through disability. So I'm really interested in see how this is going to affect me.
Well, to jump on that also, Q, just it looks like as I've gone over the bill as parts that I can, you guys know I'm very involved in the political area. I saw that they're putting loopholes in the coverage requirements also as part of their plan to try to help save, I guess. And that to me says it's going to weaken protections against pre-existing conditions, which Flex has. Is that something, I mean, what are your thoughts on that?
My thoughts on that is I'm hoping and praying.
So it's
that's one thing I don't see. I don't anticipate, at least I hope, that they don't approve anything that's going to affect pre-existing conditions, the impact pre-existing conditions. Because if you look at that, you look at the minority population, you just wiped out their ability, because, you know, as we talked about on some previous podcasts, 75% of African American men, African Americans period, they have high blood pressure. You look at the areas who have the most strokes and heart attacks, they are minorities. So what it does, it cuts down on the utilization, which cuts down on costs, which in turn provide them with more money. I was at a conference in Vegas back in April, and they literally said, I heard some really say that they don't want to cover what they consider to be preventable conditions: high blood pressure and diabetes, high cholesterol. Those are things they consider to be more lifestyle induced than a inherited condition. Now, I will say a large percentage of those situations are controllable, but then there are others. There is a segment that is disease based, like my good friend Andre. He's a physician. You know, he's been in high blood pressure since he was 25. He has extreme high blood pressure right now and diabetic, and he's 5'10", 165, 70 pounds. So it has nothing to do with his weight, but it's because that condition he inherited.
Hereditary. Right?
Yeah, it's hereditary.
So I've had multiple surgeries dealing with my kidney issues. What advice can you give me and other athletes who are aging or disability may have lost access to their vital health care in this bill pass, if this bill pass?
Well, number one, if you have a debilitating condition, definitely apply for disability. It is a long process because you have a much better chance on Medicare than you do on some of the other forms of insurance. Secondly, I'm really going to suggest that people get a professional to work with. All day long, I've been doing is fixing issues that people that is going to do it by themselves. Every single year, someone should be sitting down with you, going over your plan, because they change every single year. So they should be doing a comparison based upon your medications, your condition, your need for transportation, your need for medication, the hospital that you want to go to, and they should do a comparison to say, hey, well, Flex, you're on this particular plan. This year, that may not be the best plan based. Because their out of pockets go up and down. The cost to go to the specialist. And, I like plans that tend not have referrals. If you have a lot of conditions, I tend to care for more of a PPO than I do an HMO, so that you don't have to get referrals to go see the physician. Now, keep in mind, there is a big difference between prior authorization and referral. The referral means you can go to the doctor, but there are certain treatments that require the insurance company to approve it before it's actually implemented or provided for that type of service.
Right.
Can we jump back?
All right, we back at it.
All right, Q, just going into a couple things I hope you expand upon for me. I know that if we're going to be 100% honest, this is all to basically give tax cuts to, at first, everyone out there, but really it's it's tax cuts. So you have to make that up on the budget, right? So I know that in the bill, there's Medicaid cuts to block grants and per capita caps along the way. They're looking at expansion rollbacks of the ACA, and they're also looking at repealing the ACA surtax on investment income. So basically, that's gonna obliterate their ability to actually put money into the system. So for someone like me who works in the health and fitness industry, a lot of us are independent contractors, or we don't work enough for an organization to get their company insurance. Flex brought this up. He was an independent contractor as a professional athlete. So what are the options for us now that, let's say the worst case scenario, this passes, the ACA is rolled back, there's no more Obamacare. So what are our options at that point?
Well, I don't think they go to a point where there will be no more ACA. It's just going to cost more. They will become a gap where people don't make enough money to qualify for the AC. They make too much for the Medicaid. So it's like a gap of people who don't fall in that. But I'm telling you, as a business owner, I decided this a long time ago. And I think everybody that's independent should do this. The first thing I did, even before I started my business, I made sure I had the proper legal structure for my business. So I didn't go out and get a DBA. I didn't go out and do just something that everything is coming to me directly. I created a company bank account. I created an LLC. I transitioned that to an S corp. So now I am an employee. I am an employee. So as many small business owners, they have multiple people in their business. It qualifies you to be able to have what is called a two-member plan. So if it's a husband and wife type situation, or if it's just you and a partner, you're able to get health insurance on what's called a commercial plan through your Blue Crosses, Aetnas, and those type of places. They do have some costs to them, but as an individual, I'm just going to tell you up front, you must prepare to pay more. There is no ifs, ands, and buts about it. You're going to pay more, and you're going to most likely get less. Your deductibles are probably going to go up, and your maximum out of pockets will go up. So one of the things I really want to explain this, I dealt with it with a young lady who lost her coverage, and she's pregnant. It's a husband and wife. So a deductible, what a deductible is, that's the amount you have to pay before the plan pays anything. Okay. Now, max out of pocket is the most you would spend before the plan takes up everything. There's two components of that that really matter. You have what's called co-insurance and copays. Make it real simple. Copays are listed at dollar amounts. So you go to see your PCP, you can have a $10 copay. You go to see your specialist, it could be a $30 copay. Those things do not count towards your deductible or max out of pocket. Co-insurance is represented by percentages. So anywhere with your commercial plan, your government plan, your Medicare plan, your individual healthcare plan, anywhere you see a percentage sign, that's considered to be co-insurance, and it goes against your deductible and max out of pocket. So the deductible is what you have to meet before before the plan pays anything, and the max out of pocket is where you get to before the plan will pay everything. Make sense? Clear as mud, right?
Yeah. So
But
you
the
work
greater
with a lot.
the
I'm
great
sorry.
part about it though is that most plans have your visits to your primary care physicians. It's not a part of the deductible, so you can go see your doctor, but you may have to pay for your blood work.
Mm. So
So
you
how will
work
this
with a lot of underserved communities. What are you seeing on the ground? Are people scared, confused, or just unaware of how this bill is going to change their healthcare access?
All the above, and
Mm.
some of them are just not paying any attention at all.
That's the
They're,
scary part.
and that's the piece that really bothers me, because I think that there should be a nationwide. You have all these different association. I guess you call it what, the Southern Baptist Union. You have the Methodist. You have all these different groups that care about the people. Well, there should be massive communication. There should be church meetings. There should be meetings at the synagogue, and whatever those places are, educating people about what's getting ready to happen. Because whether people believe it or not, in those type of environments, it's mostly seniors.
Mm.
It's mostly older people. So if you have a family that now their healthcare expenses are increasing, What do you think is going to happen to the giving? It's going to go down tremendously. But I really believe that the schools and the churches has to do more, has to do something. They're not doing anything to communicate to their students, to the parents of the students, and to the congregation. Hey guys, this is something you need to be aware of. And it's not happening. I actually wrote a strategic plan for churches. That I'm actually going to the churches, trying to talk to the pastors, say, hey, these are the things we need to make people aware of to give ourselves a chance. So all that's going to happen. People are going to die. People are going to have conditions that they're not aware they have that's going to get 10 times worse. And then they finally go. I don't believe this is going to reduce the cost at all. I think it's actually going to increase the cost, because what people do when they're ill, they go to the emergency room. Now, what happens when you have all these people piling into the emergency room, and you have people that really have an emergency going on? When you go to the emergency room and there's something wrong, they can't just turn you away.
Right.
So I think it's going to cost the system. It's going to cost lives. It's going to cause financial hardship. It's going to cause pain, because the people are going to be in pain because they're not getting the appropriate care that they need.
Well, that's so in the cases of that, I mean, that was the argument for the AC initially, was they're going to go to emergency rooms anyway. Who fits I mean, I know the taxpayer initially, but what level of government fits the bill typically for local emergency rooms?
Well, the hospitals are funded in many different ways.
Okay.
You have federal funds, you have state funds, and if you look at the bill, they're cutting out a lot of that. I forgot the number. They're cutting out a lot of those resources that will be allocated to those hospitals for support. Right. And there's a lot of people raising, they're saying hospitals are going to close. They're saying that the care in the urban area and rural areas, we already struggle with care in the rural areas, getting quality of care. Now that hospital that sits out there is servicing several counties in the middle of nowhere, they're not going to have funding, because one, the insurance reimbursements are not going to be there, because they've cut down the number of people who have access to insurance. So the people that would normally come is not going to come. The reimbursements from the healthcare plans are going down. You're going to have a major funding issue. So even with people going to an emergency room, in some places, there's not going to be an emergency room for them to go to.
I really see this as gonna collapse our economy. But if someone is watching this is worried or confused, what can they do today to protect themselves in their health care, whether it's Medicaid or Medicare, or they're just unsure?
This might not be the answer that most people would expect. I think there, for lack of a better way to phrase it, there needs to be a self-reflection done, and realizing that the person that's truly responsible for your care is yourself. And we have to start taking into consideration changing our lifestyles to be more healthy. If you already have a condition or you're borderline on a condition, you how to use those services. So you're really stuck. You're going to have to pay more money. But the thing that I know for a fact, and it happened with my mother, we have to really look at our weight. I know most people want me to say a system. They want me to say the form of insurance. But the reality is that the managing our weight, managing our food intake, many of the conditions that we experience, it is our fault. People say, well, it's the food that we're eating. They put this in the food. We still have choices. If we take an active lifestyle and really start to move, like for me, I was there's such thing as a pre-high blood pressure, but since I met Flex, Greg, and Don, become much more active, and me just dropping 12, 13 pounds, I no longer have the issue with my blood pressure. That was completely in my control, right? Completely in my control. But people have to understand, you got to look at your finances, how you spend the money. You might have to look at reducing it, getting rid of the cable. Getting rid of some of those handbags. Can't go spend $200 on nails. You have to be a conscious effort of putting the money aside, because one thing I can guarantee, your health care is going to cost you more.
Mhm.
Period.
So, yeah, jumping on that one, I know that this fits right into the certain side of the aisle's talking points of cutting spending and cutting taxes. And it's always cutting, 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 regardless of what kind of reaction happens because of that. Now, if I were to look at this bill personally, the tax cuts need to be more specific and not for everyone, especially not for big corporations and the top 1%, which would actually fund enough to the government to not make these cuts to Medicaid. But in this case, what would you change about this? I guess I have to call it the big beautiful bill because that's the actual title of it. What
No,
would you call
BBB.
this
That's what I call
monstrosity?
it.
What would you change about this monstrosity of an actual enema to human society?
The first thing I would do is let the tax cuts that were implemented just totally expire. Totally expire. 100%. You know, if you think about it, many of the great men that have impacted the world, what do they come from? Impoverished communities. Impoverished communities. So I believe our nation's at a point to where it really has to reinvest in education on
Mhm.
all levels for everybody. There's so many diamonds that are in these underserved areas that have Medicaid or struggling to get by. Imagine all these people that are succeeding. um, Flex tell you he was not wealthy. He did not come out of the best situation, but it gave him drive. You don't see situations where the wealthy, a lot of them are coming out and creating things that's beneficial for the community as a whole. So I personally there need to be reinvestment into mental health. I won't say reinvestment in mental health, and investment in mental health. There need to
Mhm.
be more dollars poured into rural communities to be able to access health care. I think in the urban community, they need to be implemented education. These food deserts and healthcare deserts we have in these communities, it has an indirect impact. It comes back to the community one way or other. One way or other, we're going to pay for it. It's just who's going to pay for it. The thing, the way it's structured is that people are going to die. People are going to die. So my point would be very simple. Number one, seniors are first. Those people that are now I would say disability first, but I look at some of those conditions that people are disabled for. I can't say I agree with all of them, but those who have physical ailments they should take priority, and more resources should be placed into those to keep their drug costs, their medication costs lower, putting more money in towards education, making transportation a requirement, reducing or eliminating some of these prior authorizations just uses a bottleneck. People are really literally dying because they're having to get pre-authorization for care that never happens. There needs to be a reinvestment in the resources where you're using artificial intelligence or something to help support people to get approval for people to go see their doctors more quickly. Particularly one major carrier, I don't want to be sued, so I'm not going to mention their name. They had systematic rules in place of denying things, just hoping people would give up.
I know who that was.
I was
Yeah,
gonna say, isn't it all? It sounds like all of this is designed to confuse and make it more difficult for people, so that they can't get the health care that they need.
Well, that's
so
part
I
of
have
the reason for the means testing in the bill, also.
so one of the terms I kind of coined, putting these two words together, I call it barriers to utilization. And you see that in the ACA space a lot. And I can point specifically to them there in the Medicare components as well. For example, in the senior space, they are pushing and pushing things toward using a computer,
Mm.
dual two-factor authorization. You got to log in online, or we're going to send it by email, where you got to use the chat. There is no phone number to call. Even with Social Security now, I am literally paying people to sit on the phone and wait on hold to get somebody on Social Security. We wait, and they just cut. I would reinvest I would definitely reinvest money back into technology as it relates to Social Security and Medicare and upgrading their systems to make them more efficient. I totally agree with that because some of that stuff is just totally challenging. But now I would put money back in that space because I'm telling you guys, I am so frustrated with trying to help people that the only way you can get assistance is by calling, and you have to sit 45 minutes, an hour, 2 hours, and then they freaking hang up the phone.
Yeah.
Hang up the phone. And then those individuals a lot of times don't have the best attitude. Why? They've been yelled at all day because people that are upset because they had to wait all day on the phone. That was already an issue, and you cut out all those employees in those areas. You can't physically go to a building right now in a lot of places because there's no social security department there. Medicare has never been a physical building. So I know that's a long answer, but I would definitely reinvest resources into those issues that are relevant to seniors. I'll get more feedback from the real issues of what seniors are being done. I will look into the areas that are highly populated, particularly in the United States, that have issues in gaining access to healthcare. A lot of these people, in particularly in Houston and other areas, you have to drive all the way across town to get to what I call a legitimate physician. We've
Yeah.
talked about this before. You know, a lot of doctors in certain areas, I've talked to you guys about this before, they don't have the A student, the A physicians, right? They're gonna have
Yeah.
those B and C students that are physicians in those areas.
Yeah.
And
I don't want to get beat up over it, but it's a known fact here in Vegas that, you know, the D and C students come here and the A and B students go to, you know, hospitals like Stanford and those bigger hospitals. And, you know, I was like questioning one of my surgeons, like, but there's so many millionaires here. And he's like, they all fly out, they all fly to California or they fly to Arizona for their major surgeries. And I've even had to do that just because of the difficulties of dealing with you know, healthcare here in the hospitals.
so one of the things that I'm trying to create solutions within our communities. So I've been talking to churches and to health plans and to hospital systems. Hey, how about working with some of these churches who strategically placed within our communities? The church provides you with space at no cost. You provide the equipment and the personnel to go inside, right? You don't have to build a new building. So that eliminates the overhead for the physician. And now you have a situation where you can have a dual model, those that take insurance and those that do cash pay. So now you're providing opportunity for service for those who don't have insurance as well as those do, mixing that with a component of telemedicine. And this is a guy that's a director or a medical director in one of the largest hospital systems in the country. I don't want to say the city because I don't want to get anybody in trouble. But he said that is a great idea, but you're making an assumption that you don't understand. He said physicians, you think physicians care about the patients. They don't. They care about the money. You thinking that these physicians have some type of altruistic motive to take care of people. No, they're in it for the money. Now, granted, we know there's some great physicians out there that really like my college roommate. I mean, he has always wanted to be a doctor, but that's why he's the director. He's the medical director of about 80 nursing homes. He's doing things that he's giving back. But the issue we have is very simple. The insurance company actually wants you to be healthy and not have to go to the doctor. That because you're paying premiums and they don't have.
Oh crap!
It's internet.
No, because we're still connected online, so I think
Yeah.
it's his camera. I wonder if it died.
What is this?
If we can expand upon what your outreach to get the word out to inform the public.
So ask that question real quick. Yeah, sure.
Well, Q, earlier you talked about how you put a whole plan together for outreach to educate the public on this situation through the churches. Now that unfortunately would not hit my demographic very well. So what plans or what strategy would you put together to actually get the word out to educate the public on their options, what's being taken away from them possibility, and what they could do about it?
Number one, we are communicating heavily with doctors' offices. So as they're going in and having those experiences there, we're launching on August 1 a YouTube channel that we're going to run for 5 days a week as we go through this process. That there'll be live Q&A as well as presentation and guests on about what's happening with each plan, specifically as it relates to Medicare, as it relates to the ACA by area and Medicaid. We're opening. We've have about in the Houston area specifically. We have about 10 locations. We have 7 of them open, but we're gonna have 10 open around the city where people can physically come in and have conversation about these. We're running classes on them. The other thing we're doing, we go in the churches and we're getting pre-booked events, symposiums, Medicare 101, ACA 101, and the other, not the fifth component we're doing is that we're creating enrollment centers throughout the city. And our agents across the country, we're doing creating enrollment centers. And part of that piece is that we're going to go live every single day, and we're going to walk through examples showing people how to evaluate for themselves and then use our enrollment tool so that they can better understand. And I really believe, particularly if you're a senior, you got to get a family member engaged in your process that's technologically savvy, and you're making, because we're going to show you how to make informed decisions. Informed decision. We're going to tell you what are the most important things that you can look at. Make sure that's your doctor, your medication, the hospital, urgent care. Because one of the things we emphasize to people is as soon as you get your plan, go ahead and create your strategy. Okay, what is the closest doctor? What is the closest urgent care? Get your card to your physician. Create your portal online and have that communication. Know who is the customer service. What are the various parts of the plan that's important to you? You go ahead and make sure you have those connections. And with that, we have newsletters going out. We have news blasts. We're gonna be running social media ads. We actually spending a lot of money to get the word out. Our benefit to that is that it'll help by they using our tools, connecting to our resources, it enables to help them, and at the same time generate more revenue for our nonprofit. And our nonprofit actually pays for helps pay for premiums that people can't make their pay a premium, helps seniors with medications, help pay for transportation, help pay for different venues for people to come in and learn more about it. So we have a grassroots component, and we have a component where we're doing things digitally through social media, and help as many people as we can. And if people that hear this connect to us directly or indirectly, um, by this channel, you'll see down in the description a link that you can go to on the Flex for Life that allows you to put your information in now, and our team members can help assess for you to make changes now or to make changes in the fall. One last very, very important thing. They have shortened the ACA enrollment period, the marketplace. So instead of going into the middle of January, it's going to cut off December 31st. And the biggest thing is a lot of people enroll throughout the year, and a special enrollment period is based upon being 150% of the federal income poverty level. That's going away. So it's going to take extreme conditions and adjustment for people to get insurance through the middle of the year. If you want a marketplace, you need to lock those data in. That's why with the Flex for Life campaign that we're doing, and you look down in the description, look at the link, share the link with as many people you can, so we can do the assessment and get things together. So when November 1 comes, you're getting your stuff taken care of, and you don't have anything to worry about. Those people wait until the last minute, system bogs up, systems go down, people not able to answer the phone, all kind of issues happen. Do not wait. That's probably the best thing you can do is do not wait. Make sure that you're taken care of and that you're a family member. If you have a parent that's a senior, help them through the process. Be there for them.
LaQuentin Jenkins, the insurance man, I just want to thank you so much for taking this time out and going over this very important yet scary information on how the world is just changing, how United States is just changing right before our eyes. Thank you so much. I appreciate it. We all appreciate it.
Bless you. Have a great day.